Good afternoon and welcome, everyone. Today is Heart Valve Disease Awareness Day, and thank you for joining the National Caucus and Center on Black Aging, NCBA, as we host the webinar on heart valve disease, its effects in the Black community, in conjunction with the Alliance for Aging Research. Our presenters today are Katrin Werner Perez and Aaron Horn Jr., MD. Katrin Werner Perez is the Health Programs Manager with the Alliance for Aging Research. She serves the organization's health programs by production and distribution of health education materials, relationship building, and project management. She holds a Bachelor of Science in Health Promotion and Education with an emphasis in consumer health from the University of Utah. Our second presenter, Dr. Aaron Horn Jr., MD, is a structural and peripheral cardiologist who treats people across the gambit of cardiac and vascular issues. His area of expertise includes taking care of patients with chest pain, palpitations, shortness of breath, leg pain, and episodes of syncope, which is when a patient loses consciousness. Dr. Horn's clinical focus is on the fastest growing population in the US, those who are 85 years and older. Dr. Horn holds a Bachelor of Arts with honors in public policy from the University of Chicago, Illinois, a Master of Business Administration in Economics from the University of Chicago, Booth School of Business, a medical degree from the University of Chicago, Pritzker School of Medicine, several fellowships with the Johns Hopkins University School of Medicine in Baltimore, and several board certifications with the American Board of Internal Medicine in interventional cardiology and in cardiovascular disease. When not treating patients, Dr. Horn enjoys jogging and spending time with his wife and two children. He is also especially passionate about the treatment of and educating the community on the importance of health equity and how focusing on those most in need can also help bend the cost of care within cardiovascular care. And Dr. Horn, I'm looking forward to getting more information on that part. So thank you. Welcome, Katrin. Welcome, Dr. Horn. We appreciate you joining us. The floor is yours. Thank you.
Thank you so much, Angela, and thank you all for joining us today for this very important webinar, Heart Valve Disease, Its Effects in the Black Community. My name is Katrin Werner Perez. I'm the Health Programs Manager at the Alliance for Aging Research. And I'm going to be giving a brief overview of valve disease today in our Heart Valve Disease Awareness Day. So the Alliance for Aging Research is the leading nonprofit organization dedicated to changing the narrative to achieve healthy aging and equitable access to care. Based in Washington, D.C., the Alliance strives for a culture that embraces healthy aging as a greater good and values science and investments to advance dignity, independence, and equity. In 2017, the Alliance conducted a survey that found that 3 out of 4 Americans knew little to nothing about heart valve disease. The Heart Valve Disease Awareness Day campaign was started at that time in order to increase recognition of the specific heart valve disease risks and symptoms, improve detection and treatment, and ultimately save lives. Heart Valve Disease Awareness Day takes place every February 22nd during American Heart Month. On this day and throughout the year, The campaign partners over 127 nonprofits, advocacy organizations, professional societies, foundations, hospitals, and heart centers join forces to help spread the word about valve disease. And while our partners educate about heart valve disease awareness throughout the year, a dedicated day like today allows us to collaborate and amplify each other's messages. If you're interested in learning more about this important awareness day and finding out how you can get involved, visit valvediseaseday.org and follow us on social media at Valve Disease Day. So to understand more about valve disease, we need to understand how the heart works. The heart is a powerful organ that's responsible for continuously circulating blood throughout the body. The heart's four chambers squeeze and relax in a coordinated manner to pump blood to the lungs and through the circulatory system to deliver oxygen and nutrients. Between each of the heart's chambers is a valve. A valve is a thin leaflet of tissue that keeps the blood moving in only one direction and with just the right amount of force. The valves keep blood from leaking backwards by only opening one way and sealing tightly as soon as blood passes through. There are four valves: the tricuspid valve, the pulmonary valve, the mitral valve, and the aortic valve. So valve disease is a type of heart disease that involves damage to one or more of those four valves that causes them not to open or to close properly and disrupts blood flow. If a valve doesn't close completely and allows blood to leak backwards, it's called regurgitation or insufficiency, and you may have heard this referred to as a leaky valve. If a valve doesn't open fully to allow enough blood to flow through, it's called stenosis and may also be referred to as a sticky, narrowed, or stiff valve. A valve may also fail to open fully due to an obstruction. Each of the heart's four valves can have regurgitation or stenosis or both, although the aortic and mitral valves are the most likely to be damaged. The most common types of valve disease are mitral regurgitation, mitral stenosis, aortic regurgitation, and aortic stenosis. So valve disease reduces blood flow to the body and it forces the heart to work harder, and that often causes a number of symptoms. Many of these symptoms will only happen during exercise or activity, but as valve disease worsens, they may also happen while resting. Symptoms can be remembered by the mnemonic LISTEN. So L is for feeling lightheaded, faint, or dizzy. I is irregular heartbeat, heart flutter, or chest pains. S is shortness of breath after light activity or while laying down. T is tiredness, even if you've had plenty of sleep. E is edema or swelling of the ankles and feet. And N is not really feeling like yourselves, maybe missing out on some daily activities. Without treatment, valve disease can lead to serious complications, including arrhythmias, congestive heart failure, stroke, other heart disease, and even death. These complications can significantly impact quality of life. It can make everyday activities difficult and can lead to disability and loss of independence. So what are our risk factors? Valve disease is usually caused by wear and tear, disease, or damage. So the most common risk factors for valve disease are older age, congenital abnormalities, family history, infection, radiation to the chest and certain chemotherapies, cardiovascular diseases and conditions, and other health conditions. It's important to note that racism, either structural or interpersonal, negatively affects the health of people of color with many diseases, including valve disease. The disproportionate impact of risk factors for heart valve disease on people of color is just one example of these health disparities. Black Americans experience risk factors for valve disease, such as high blood pressure and heart failure, at higher rates and earlier ages than their white counterparts. And this makes the average age of valve disease onset among Black Americans younger. And because it's a disease that's often thought of as age-related, Black Americans are more likely to have their valve disease go undetected and untreated than whites. So to start to touch on the conversation of health disparities in Black and Hispanic populations, this statistic is a great example. So right now, 1.6 million people are living with tricuspid heart valve disease in the United States. Of those that are undergoing tricuspid surgery, 60% of patients are white, while Black and Hispanic patients represent only 10% and 6% respectively of those surgeries. So to dive deeper into the specific impacts of valve disease and health disparities, I'm going to hand it over to Dr. Aaron Horn.
All right. Hello. Good afternoon. Thank you again for the opportunity to share some information with everyone today. I want to acknowledge and thank the Alliance for Aging Research, and also like to make sure that I acknowledge the unique opportunity to spend a little bit more time. I've partnered with the Alliance for Aging in the past, but really excited. My first time presenting to the membership and extended community for the National Caucus and Center on Black Aging. And this is a presentation that I'm hoping will truly be meaningful for those all that are engaged today. The benefit of being able to do these type of interactions via telemedicine, if you will, or via this type of platform is that these webinars enable us to have a greater reach to people, regardless of their ability to be able to be mobilized to go to a particular location, cross geographies, and that's really special. But what I don't want to lose is the ability for us to interact. So please, throughout the course of this interaction, we will have time for question and answer at the end of the meeting, but I want to make sure that we make this good use of your time. So if there's any comments, questions that any of you have during the course of this presentation, please don't be shy to put something in the Q&A, or you can raise your hand emoji, and I promise that I'll pause and address the topic, and then we'll continue with the presentation. So I really want to make this interactive, and that's how it's going to be most useful for everybody. So next slide, please. So we're going to jump into this. We're going to lean into this. I'll just sort of closely, I'll sort of at 1,000 point view, recap what it is that my colleague just stated regarding heart disease. Okay, so again, just to recap, heart has left, right, top, bottom, separated into 4 chambers by valves. Okay, so those valves over time are going to become stenotic or regurgitant. What does that mean? That means stenotic, I think, is a little bit more intuitive. That means that the valves don't open as well over time. And regurgitant means that the valves become a little bit leaky. So the analogy that I always use is like when you have a push door and you have a vacuum seal on it. When that door is brand new, you push the door open and the suctions close. Push it open, suctions close. Over time, you push it open and it swings back a little bit before it closes. And so that's what we mean by regurgitation. And so valvular heart disease, I think, is an area within cardiovascular medicine where cardiologists have not done a good job in terms of really communicating effectively with our patients about what that usually means. I think that as a medical community, we've done a good job talking about heart attack and stroke. So we know that if somebody has chest pain, the first thing you're going to ask yourself is that person having a heart attack? And we're very aware of that, which is great. And we've actually done a good job in decreasing the amount of people that have bad outcomes when they have those type of events. Same thing with stroke. We know if somebody has slurred speech or one side they have a facial droop, we know that something potentially bad is going on. We think that they're potentially having a stroke, and we make sure that we activate our local EMS services to make sure that we take care of those patients. Where we have a lot of work to do is talking about valvular heart disease. This doesn't flow off of our tongue as much as a heart attack or a stroke. So what is valvular heart disease? So, like we mentioned, the heart has a left and a right, top and a bottom, separated into 4 chambers by valves. So as my colleague noted, we have the mitral, tricuspid, pulmonic, and aortic valves. The valves that I'll sort of focus the most on, because not only are they the most common, but the ones that I really want us to pay attention to most closely today is the aortic and the mitral valve. So since, again, we're talking to the National Caucus on the Center on Black Aging, it's important that we know that first and foremost, the fastest growing population in the United States are people 85 years of age and older. That's an incredibly important point that I make. Now, we know that unfortunately with the pandemic, we lost a disproportionate amount of our elderly family members, loved ones, patients. And so that number, unfortunately, was skewed down. And unfortunately, as we know, a disproportionate amount of those patients that we lost during the pandemic were people of color, patients that had comorbidities, such as hypertension, diabetes, hyperlipidemia, high cholesterol, that is. And unfortunately, those patients have disproportionately continued to be overrepresented in the Black and brown community. And that said, the fact is that we're living longer, and it's important that we pay attention to valves such as the aortic valve in particular. The aortic valve is the main valve that lets blood leave the main pumping chamber of your heart and go to your brain and all of your vital organs. So it's really important that we pay attention to this, because when you're 75, 65 years of age and older and you're having chest pain, it might not just be because of the possibility of having a heart attack. It might be about the fact that your valve is not functioning properly and therefore not getting blood supply to your brain and all of your vital organs. So I'm going to go through a set of about 20 slides. And again, I'm going to trust that my colleagues that are manning the chat are going to interject when necessary to help me, tell me when to stop and explain something a little bit better, or there's somebody that wants to interject something, and we'll make this as interactive as possible. So look, what are the things that are going to affect how people, as we get older, 65 years of age and older, interact with the healthcare system? Now, before I get into that, I want to take a half a step back. So I spend probably 70% of my patients in my practice are older than 65 years of age. And that's by choice. I take care of this particular patient population because, again, it's a growing patient population, a special patient population that has unique needs and needs to be thought of through a much more sophisticated lens, I believe. And so what happens is, as we get older, sometimes society historically has had, I think, a skewed view on how we look at our older patient populations. What do I mean by that? So when we look at patients that actually are 65 years of age and older, and maybe that will change as we talk about what Medicare looks like 5 years from now. But we're looking at patients that potentially are no longer drawing a W-2, meaning that they're no longer a part of the quote unquote workforce. And so questions are asked about, well, how do we view these particular patients in our society? So what's interesting is I'm involved with a group of folks that have looked at the money behind this, the economics. And we find that patients 65 years of age and older actually contribute into billions of dollars to society. What do I mean by that? If I take a personal anecdote, my father is 84 years of age, and the amount that he contributes to with childcare for my wife and I is innumerable. When you look at volunteerism, these are really, nuts and bolts, hard ways in which older patients are contributing to society. So it's important that we understand that, embrace that, and make sure that we're cultivating society that makes sure that we're prioritizing these particular patients. And that means looking at their healthcare in particular. So as we get older, we have to look at, what does equitable healthcare really look like? What is the issue with regards to affordability? What awareness of what needs these particular patients have? What's appropriate? When we look at issues about cultural circumstances and health, how we go about making sure that we're speaking to people in appropriate ways, that's incredibly important. And when we look at capacity to make decisions, that does not mean cognitively. What happens is, as we get older, you have a larger subset of people who are involved in your care. You have kids, you have grandkids. So it's important that we look into all of these things. But again, we're not going to shy away from the fact that experiences of racism have been associated with reduced trust in healthcare system and lower patient satisfaction. The fact is that many of us within our inner circles still know people, if not impacted directly, have some close association with the Tuskegee experiment. And there's no way that you can go through something like that and make sure that you haven't been adversely impacted in some way. So that's something that we just have to open our eyes about and understand why the trust deficit exists. It exists starting back from that. We don't have to go back to slavery. This happened in many of our lifetimes. Among Medicare beneficiaries, age 65 years plus, patients of colors are more likely to report delays or challenges in healthcare access than white patients. Up to 8% of Americans age 65 plus have skipped a physician visit or medical test treatment due to concerns about cost. We'll talk about social determinants of health, which is very real. We'll get into that. And then we know, after adjusting for age and health status, patients treated in rural clinics, and this is incredibly important, actually have the worst underutilization, because, I'm practicing, and I see a couple of things coming up in the chat box here. I'm located in northern New Jersey. And what happens in these urban metropolises, I probably within a 20-mile period of a 20-mile radius, probably have at least 20 hospitals around me. But you go into these rural areas, you might not be able to reach a tertiary care facility, within 60 miles. So that's something that we definitely need to be aware of. Next slide, please. So Americans age 65 plus are already a diverse patient population. About 25% of Americans age 65 plus belong to a racial or ethnic minority. And so that's really interesting because if you look at the most recent census, African Americans only make up 14% of the overall U.S. populace, right? That's according to U.S. Census Bureau data. But yet 25% of patients, of people 65 years of age and older happen to be African Americans. So think about that. Among Americans age 65 plus, women outnumber men. I think we know that life expectancy is higher for women and men, but white women more so than black women. And between those two is white men. So black women and black men have the least life expectancy, but black women live longer than black men. And then we look at the economics of things. Nearly half of Americans age 65 years and older report an individual income less than $25,000 per year. Okay, so we don't have to deal with the fact that this is something that, takes into account that you have to, figure out, where you're going to live, what you're going to eat, what are the needs of your kids and your grandkids. And that's not even to then talk about the fact that you got medications that you need if you have certain chronic conditions such as diabetes, high blood pressure, and the like. Next slide, please. So as I mentioned before, we're a diverse patient population as we get older. It varies across geography. I talked about in terms of the rural disposition, and also it's interesting to look at what one's needs are as they get older with regards to access into healthcare environment. So you look at, a lot of snowbirds live in Florida, and you can see that disproportionate 20 to 23% of the population there being 65 years plus. And then if you go to the furthest northeast there, you can see a higher percentage of, again, patients that are older. We looked at, again, older folks living in these rural populations. But then I think that the last slide here, looking at the type of more specialty interactions you need as you get older, it's very complicated, right? Because we just mentioned the fact that many of these patients are living at less than $25,000 a year, and you will go to these subspecialty providers. You're talking about oftentimes more expensive care as well. So that's something that we need to really wrap our brains around. Next slide, please. So the population of Americans age 65 plus is anticipated to continue to grow and become increasingly diverse. So again, we're going to continue to be a melting pot. And from my perspective, that's something that's very reassuring. And that's something that I think makes me smile as I look at raising two kids in this environment. And we want it to look like the United Colors of Benetton. We believe that diversity is something that is enriching, because oftentimes we look at things through a very, I think, provincial lens. Often as Americans, this world is a lot bigger than the U.S., but within the U.S., we need to embrace our diversity so that we can also then have a better appreciation of the world around us. So the number of Americans 65 plus projected to increase by 75% between 5 years ago and 2060. Just think about that. That's incredible. Projected population increases between 20 and 19 are expected to be greatest for racial and ethnic minorities. Among Americans age 65 plus, women are expected to continue outnumbering men. And by 2040, the proportion of Americans age 65 plus in each state will range between 10 to 60 to 27%. And one in five Americans are expected to be by 2030. So you're talking about 5 years from now, 65 years plus. So I think that's something that's very encouraging. Next slide, please. Prevalence of heart disease, including valvular heart disease, is expected to rise as the population ages. As I mentioned before, if you recall that between 26 and 29% of patients, so 26 to 29% of patients older than 65 years of age and older has aortic stenosis. 1 out of every 8 adults 75 years of age and older has moderate to severe aortic stenosis. And the fastest growing population in the United States are people 85 years of age and older. So again, as I mentioned, we do a great job talking about heart attack, stroke, but again, cardiovascular disease is the most prevalent disease state in the United States, even taking into account cancers. So again, within that cardiovascular disease sphere being the most prevalent disease state, what I'm saying is now it's not just going to be heart attack and stroke, but disproportionately more looking at valves such as the aortic valve and the mitral valve, okay? Next slide, please. So the prevalence of heart disease, including valvular heart disease, as I mentioned before, is going to continue to increase. The population of patients with aortic stenosis is diverse, with about 16% of patients belonging to a racial or ethnic minority. So the prevalence of AS is expected to grow as the U.S. population ages. Next slide, please. So valvular heart disease test disparities. So let's again just take a step back again. So valvular heart disease. I talked about aortic stenosis. Another valve I'll mention is mitral valve disease. So mitral valve separates the top from the bottom portion of your heart on the left side of your heart. So, the most common heart disease state still in the US is patients having blockages in their arteries. And what happens is if you have blockages, you get decreased blood supply to the heart muscle. The heart muscle can then become weaker. And if the heart becomes weaker, remember that regurgitation I mentioned in terms of that suction door that gets leakier over time, and the blood continues to go from down to up as opposed to up to down. That valve is going to continue to not be able to get enough blood flow to your brain and all of your vital organs. But what happens is in order to know that that's going on, you actually have to actually be diagnosed. And the reality is that even when African Americans in particular go to the doctor, they're less likely diagnosed with these particular disease states. And not only that, but when they actually then are diagnosed with the disease state, they're less commonly treated. And furthermore, as we go back to, and it's multifactorial, but it's well documented what it is, and it's not just, in fact, a mistrust. There's implicit bias. There's really a lot of mistakes that happen with regards to our ability to form these productive relationships, and therefore we have this combination of patients many times missing subsequent appointments with their providers, and then when even offered access to particular treatments might refuse it because they don't know that that actually is the right diagnosis and treatment modality for them. So we underdiagnose these disease states in people of color in particular. We miss the diagnosis in them, and then we also, once we either miss or even if we do actually diagnose them, these patients get undertreated. Next slide, please. So diagnostic tests vary for patients presenting to the emergency room department, presenting with chest pain. So as I mentioned before, the patients, so this is something that's interesting, the patients that are treated least aggressively for heart disease in the United States are women, okay? And then I'm sure that you won't be surprised, Black women treated less aggressively than white women. White men have been historically treated most aggressively for heart disease, and Black men the least aggressive. And again, when I say undertreated, so I see and we'll get through some of these. I don't want to get too disconjointed, but I do appreciate the questions coming in. What I mean is undertreated. So for instance, I tell you, you have a patient has a blockage in one of the arteries that give blood supply to their heart muscles. And the ways that we can potentially treat that might be either medications, stents, or surgery. It would be more common in that kind of arcane example, very basic example I'm giving you is that they'll be more likely to potentially get nothing as opposed to medication, balloon stents, and or surgery. I can make a specific reference to that as a potential aortic valve disease, and I'll give you that example later, meaning that somebody has aortic valve that isn't working, and it's clear that it isn't working, but that patient not being offered a replacement of that aortic valve, and instead would say, well, why don't we watch that moving forward and see how you're doing 6 to 12 months from now. Next slide. So again, as I mentioned right before this slide, valvular heart disease, surgical device treatment disparities, similar to other surgical procedures. So if you look at, again, 4 very common diseases that we treat. So we talk about bypass grafting. People have blockages and they need, open heart surgery for coronary bypass grafting. If you look at carotid endarterectomy, people have blockages in the arteries that give blood supply to the heart muscle. If you look at total hip arthroplasty, what does that mean? Patients fall, break their hip, so they need to get that treated. And then heart valve replacement. So if you look at on this slide, the rates per treatments per 100,000 people, and you look at it on year on the horizontal slide. So the Y slide is the one that goes up and down. The horizontal X and Y, that's the years from 2012 to 2017. So you can see that for each of these particular disease states, that white people get treated more aggressively than any other underrepresented minority. Now think about this for a second. We have clear data that demonstrates that underrepresented minorities have a higher predisposition for comorbidities, for particular that as if you look at coronary artery disease in particular, right? If you look at coronary artery bypass grafting, we know that African Americans have higher rates of high blood pressure, diabetes, hyperlipidemia, end-stage renal disease on dialysis, in certain instances, tobacco use. So, but if you look at on the left side of coronary bypass grafting, right, blockages. So Black folks have higher prevalence of all those disease states, that risk factors that contributed to needing bypass surgery, but you can see have disproportionately less access to that particular therapy. Same thing, heart endarterectomy. Same thing, heart valve replacement. So this is the data is the data, okay? So it's important that we don't, put our head under the sand, but understand, acknowledge that these issues exist, and then try to continue to work hard and diligently, assiduously on trying to make sure that we do something to bend this curve. Next slide. So now we talk about, transcatheter aortic valve replacement. So I happen to be the first fellow trained at Johns Hopkins in replacing the aortic valve. So again, as I mentioned, the heart has left, right, top, bottom separated into 4 chambers by valves. So on this slide over here on the right, you see the aortic valve replacements on the left and mitral valve replacements on the right. I'm going to talk about the aortic valve replacements first. And so what we know is that in 2001, and France was the first transcatheter aortic valve replacement. What does that mean? That means if you have a blockage in that valve, so you can't get blood out of your heart because the valve just isn't opening. The valve won't let blood get out. So historically, the only way that you could fix that was opening up somebody's chest and replacing that valve. But now we have mechanisms by which we can use these more advanced catheter-based technologies, and through an IV in the artery in your groin, replace the aortic valve. That's in particular patient populations, okay? And so what we've seen is that this particular treatment modality is incredibly successful, regardless of if you're black or white. If you get access to the treatment, you actually do well. But you can see that the reality is that African Americans have had less access to this particular therapy. Next slide. So we know that over a 10-year period of time, that only 3.8% of African Americans have gotten access to this transcatheter aortic valve replacement. Let's talk about why that matters. So let's say that that aortic valve is not opening. So we know that, so if that's the case, then you have something that's called severe aortic stenosis. Okay, if you're having symptoms from it, that means you have severe symptomatic aortic stenosis. So we know that if that is untreated, and we've already noted that African Americans are underdiagnosed and untreated for valvular heart disease. So we know that there's a 2-year, 50% mortality associated with untreated severe symptomatic aortic stenosis. What does that mean? If your valve is not opening and you don't get anything done to fix it, you have a 50% chance of dying in 2 years. And we know that over a 10-year period only 3.8% of Black people in the United States have gotten access to this particular valve. Next slide. So this is something that is something that I've been working closely on with the Association of Black Cardiologists. In February, we just convened another roundtable, and we'll provide access to that resource via abcardio.org, Association of Black Cardiologists, where we come up with a policy prescription for this. So we came up with extensive, it's a 36-page document where we have recommendations to the payers. I see a lot of questions about Medicare, Medicaid. Does Medicare pay for these procedures? They do, but what happens is oftentimes, many of you on the call will understand that you also have secondary insurers. And sometimes there might be instances where Medicare might pay a portion of this procedure, but then count on your secondary insurer to pay for the remaining of the procedure, and that can become complicated. But nevertheless, we have a policy subscription for how we believe that Medicare, CMS in particular, Center for Medicare and Medicaid Services, should address this. We talk about how our industry partners, the people that make these valves, should address this. We talk about how our partners of our community, civic organization, clergy, all should be involved, and most importantly, partnering with patient organizations and entities such as the National Caucus and Center on Black Aging and the Alliance for Aging Research, with whom the Association of Black Cardiologists has a long relationship with, and trying to find solutions, not just pointing out the problems that exist. Next slide. So the AVR treatment rate for patients with aortic stenosis decreases for underrepresented races and ethnicities. So regardless of whether or not you're going to get this less invasive procedure that I mentioned, this transcatheter platform or surgical aortic valve replacement, we know that African Americans, again, continue to get less access from this treatment. And so it's something that we're all aware of now, and it's important that we continue to bring attention to this topic and try to work diligently to come up with clear solutions, which is the reason why I mentioned that that presentation that we did in February of this past year, that again we'll make available to everybody on the call here today. Next slide, please. So look, this is also not just a race ethnicity issue, it's a gender issue. So women are 9% less likely than men to receive aortic valve replacement. The increase in TAVR volumes over time has been slower for women than men. Among those treated with TAVR, women have more vascular complications than men, despite having less vascular disease prior to treatment. So this is something that, again, we need to continue to focus on when we talk about health equity. We're talking about underrepresented minorities. We're talking about women. We're talking about based on your geography, patients that are living in rural areas as opposed to these urban metropolises. So we're trying to make sure that we're meeting the needs of those most in need. And then again, an important part of this also is socioeconomic status. And that oftentimes correlates with geography, with rural environments often being less socioeconomically secure. And also, if you look at issues with regards to race, ethnicity, underrepresented minorities oftentimes also are in socioeconomic strata that are more consistent with that $25,000 annual a year, in terms of resources available for the multitude of their needs. Next slide. So we also know that patients with advanced stage are less likely to undergo AVR than younger patients. So again, these octogenarians, are not getting access to as much care. But it's important to note that as we become an older patient population, we really start to embrace this topic of shared decision-making. One of my colleagues, Megan Colwright, has published extensively on this topic, and I work closely with her. And there's a really important point that I'd like to bring up here. I think historically, oftentimes, and I think it's important to note that medicine has and is continuing to change. It's no longer the matriarchy or the patriarchy it once was, where you just do whatever the doctor tells you to do. It's important, especially as you get to be your 70s and 80s, that you really do feel like you have a partnership with your healthcare provider, and you have a give and take, and you're comfortable with that relationship, so you can explain who it is that what it is that's important to you. I can't tell you what's important to you. So it's really important that you're involved in that interaction with your provider. As it pertains to aortic valve and mitral valve disease and valvular heart disease, we have adopted this heart valve approach, which is a class 1 recommendation by our guidelines when you look at the American Heart Association and American College of Cardiology. So it's important that it's not just the doctor telling you what treatment you can or can't have, but you're communicating with that care team and explaining what your preferences are for your quality of life at this time and stage in your life, and you work in concert with one another in order to make sure that we're on the same page with your treatment goals moving forward. Next slide. So we look at, again, in terms of race-specific population-adjusted TAVR treatment, it varies across geographic regions. Again, what you'll find is regardless of the geography, we can see that Hispanics and non-Hispanic Blacks and other minorities get treated least aggressively as it pertains to these, advanced technological treatments. And so it's important that we're cognizant of this. And part of this also is making sure that we hold physicians accountable, to making sure that we're aware of our implicit biases, our under treatment pathways, the implicit bias within the healthcare system that has prevented underrepresented minorities in particular in terms of getting the care that they deserve. But it's also important that as the end user, the patient, that you're aware of these particular data and that you're advocating for yourself and that you are comfortable with the care relationship that you have with your particular provider. And if not, it's important that you are comfortable asking for a second opinion or making sure that you're getting all of your questions answered. Next slide. So as I noted before, in terms of geography, but also, by income. And, this is obviously not, some type of sociological discussion about the best manifestation of healthcare delivery in the United States. But, I think that we could all understand that, if you have more money, I guess you should be able to afford a bigger house or a bigger car if that is what you so choose. But if you look at the morbidity and mortality associated with particular disease states, as I mentioned, 50% chance of dying if your aortic valve isn't treated. you would think that the limiting factor to you potentially being able to have a sustainability of life and appropriate quality of life isn't just the amount of money that you have, which happens to correlate with race in many instances. So that's something that is very disconcerting to me, and something that I hope that we're a little bit more introspective about as a society, and making sure that we are doing right by patients based on the, again, significant morbidity and mortality associated with the disease state. And valvular heart disease, I think, is a unique sort of discussion point for that. Because of the increased technologies, there's increased costs associated with the equipment that we use, right? So I would argue that in the United States, no matter of, even though it's clear that there are there's worse outcomes, decreased access, also under treatment in disease states such as heart attack, stroke. I would say that no matter where you are, if you come in with a heart attack and a stroke, you're going to be treated for that particular condition, regardless of your race, ethnicity, gender, or socioeconomic status. And I'm not convinced that that same thing is happening with aortic valve disease, valvular heart disease, and the morbidity and mortality is still very stark for this particular disease state. Next slide. So how do we fix this? Next slide. And a lot of this data is also in my the slide deck that I mentioned in terms of the valvular symposium roundtable that we had this past February in DC. But it's important that so first of all, I want to take a half step back and say, this is not something that is so complicated that it cannot be fixed. We know what needs to be fixed. Oftentimes when we talk about issues regarding health equity, a lot of people say, oh, well, it's too complicated. We can't fix it. We know how to fix it. Okay. At the end of the day, we need team-based healthcare. Okay. So we need multidisciplinary teams so that there isn't just one person in the vacuum making a decision. And I think that multidisciplinary team actually does, in fact, impart some accountability, because it includes some transparency and hopefully mitigate some of our individual implicit biases. We need to make sure that we acknowledge that disparities exist and they need to be addressed. This isn't something that we can just put our head under the covers and think it's going to go away. As I just noted, over 10 years, only 3.8% of African Americans are getting treatment with transcatheter aortic valve replacement, even though you have 50% dying untreated once you have this disease state. So we have to acknowledge that it exists. We need to work in a culturally competent environment and work in a shared decision-making process mechanism, as I mentioned, with the work of my colleague, Dr. Colwright. We need to address policies with payers such as Medicare to make sure that these treatment modalities can be afforded, as I mentioned, but it's also in the policy prescriptions in our roundtable discussion. We need to enhance physician awareness and understanding about these disparities. I mean, it's just a fact. We have to accept that. We need to develop partnerships between all relevant stakeholders, patients, payers, policymakers, clergy, members of the community. So we got to work together. We have to diversify the workforce. We need more people in our pipeline from underrepresented minorities that are focused on this, such as I am. Association of Black Cardiologists is a volunteer organization. I'm taking time out of my day to do this because it's something that's important to me. We have to change the research paradigm. We need to make sure that the development of these technologies, drugs, technologies that we do are actually going to treat the patients that are most at risk. If you don't have people of color in these clinical trials, the therapies and the medications that you don't know that they're going to be generalizable to the patients that are most in need. So we need to make sure that they're not only patients, but physicians that are helping to run these trials. And, we need to improve patient access and accurate diagnosis. We often throw this word around, patient education. I go back and forth with it. I don't really love the term. I think that if we don't have a familiarity about it, doesn't mean we're not educated. My grandmother had a second grade education, according to my father, and she was the most educated person I ever met. So I don't know if important education. I think it's about making sure that people are aware of what it is that we suffer from at different stages of our lives. So I think I went a little bit longer than I anticipated, but I think we have about 10 minutes for a Q&A. So I don't know who's facilitating that part of the interaction, but I'll defer to one of my colleagues on the panel with me. But again, thank you again for your time and allowing me to participate today. And really honored to be here to be a part of this conversation.
Thank you, Dr. Horn, and thank you, Katrine. I'm going to facilitate the Q&A today. Your presentation was thoughtful and quite meaningful. So again, thank you very much. And I'm going to jump right into the chat. The first question reads, could you speak to provider bedside manner? When is it time to look for another provider?
Once you ask yourself that question.
Okay.
I'm being
Okay.
very direct, right? So, so healthcare is a consumer good, right? The reality is that there aren't a scarcity of physicians. When you go buy a home and you go buy a car, if somebody, doesn't treat you in a way in which you feel comfortable, I bet you go get a second opinion, right? And there's
Yes.
nothing more important than your health. So when you feel as though there is some deficit there, then I would encourage you to maybe first express your concern that you might not be able to communicate with that particular provider in a way that you feel most comfortable. Just want to share that with you. Want to figure out whether or not there's a way that I might be able to express myself in a way that you might let me feel first, share my thoughts and then let me finish before interjecting. If is that an exchange that you're comfortable with? If you feel like there's subsequent pushback, be like, well, I think I would prefer a second opinion at this time.
Well, I'm glad you spoke to that, Dr. Horn, because many people have white coat syndrome and they don't question or interact with their care provider. So I'm glad you spoke to that. Yep. Our next question reads, will AI play a part in cardiology of the future with all senior patients?
Absolutely. I mean, there's no question about it. There's no running from AI, just like there's no running from disparities that exist, right? And so the question is, how do we harness that? I think in some ways AI, with regards to valvular heart disease, potentially could be very helpful because we talk about this underdiagnosis. I saw, peripherally in my vision while I was presenting that people were asking about, what do we mean by underdiagnosis? What do we mean by undertreated? So in order to actually diagnose somebody with aortic valve disease, for example, you need to be able to put a stethoscope to somebody's chest and listen to whether or not there's a murmur that, actually demonstrates a manifestation of a decrease in the narrowing of the orifice or the area of that particular valve. So the degree to which we, develop more technologies that measures flow impedance in different areas of the body, your smart watches and such tells you how fast your heart is going and things along those lines. But I think that the way we integrate that AI into our respective practices is going to be very important. And what's going to be the important part, though, is how you interpret that data, right? And so, I think it's good to get the data, but you need to go to a trusted source in terms of how to process it moving forward.
Okay, thank you very much. And you spoke to Medicare, Medicaid, and private insurance covering AVR. Can you speak to that a little bit more? When a person goes into having their annual wellness exam, how do I know that I am getting the quality of care, especially when it comes to this cardiac care? How would I know?
Sure. So, I think that this is a big piece of it first, right? Bring it to your attention. I mean, once we, so once, certain communities found out about in terms of just how dangerous diabetes was for certain, right? That was first in terms of just making them awareness about that. And then, you look at initiatives that are going on in urban cities in terms of trying to address issues of food deserts and things along those lines, right? Because, if you look at the Black community in particular, the ingenuity is there. Once we're aware that this is an issue, we're going to break our own foods, right? Making sure that the kids just don't have access to, Cheetos on the way from the store down the street. So in terms of, I think, bringing the awareness to, I'm getting older. I know as I get older, like I gave this example earlier in the conversation, when you get older as a man, I know I need to check my prostate. Women that have breast tissue know that they need to be managed for, the possibility of any, breast pathology. But as we all get older, we know that valvular heart disease is something that's going to be a part of our healthcare landscape. And so I think that, again, bringing that to the attention of your provider, these are the 5 questions that I have today. If I'm a man, where am I with my prostate screening? Where am I with my issue of valvular heart disease? Those type of questions that, we need to. And I think as a system, to your point, so there are certain questions that we ask when you go to your primary care provider in terms of your wellness visit. They're going to say, are you safe at home? Right? What's your mobility like? Can you drive? Do you have food scarcities? I think that, issues regarding valvular heart disease need to be integrated into that.
Okay. And to build on that, for those of us who aren't 65, in our late 40s, early 50s, are we to have the same conversation, especially if we know we have a family history of valvular heart disease?
Absolutely. So I say this all the time, I'm practicing a long time now. I don't know if people like it or not, but I say there's a reason why your kids look like you. No, I'm just telling you, true, right? It's genetics. Genetics are powerful. So there's no question that I talk about this disease state of the aortic valve affecting people 65 years of age and older. Now that's mostly tricuspid aortic valve disease. There's something called bicuspid aortic valve disease that presents much younger in life. So these are questions that you definitely, valvular heart disease is a big part of the heart care landscape. Now, so you should ask that question, and genetics absolutely matter. So if you have family members that have the history of heart disease early in life, that's something that you're going to, you need to ask about. And there are certain cardiomyopathies that we won't get into, but disproportionately affect the Black community, things like amyloidosis and things along those lines. So those are questions that we definitely need to bring to the attention of your provider. But it all goes back to making sure that you have a comfortable relationship with your provider and you feel comfortable bringing these things to their attention.
Okay. Thank you. And another question in the chat reads, some of the symptoms of AVR mimic menopause. While I'm not 65 plus, how do I approach my care provider to take an interest in my heart?
Yeah, no, I think it's a great point because again, as I mentioned earlier, so everybody's manifestations of heart disease are different. So what happens is the reason why, when we think of, and this is part of the underdiagnosis also. So historically, how we figured out how we thought people were having a heart attack, we asked middle-aged men and middle-aged white men in Massachusetts, what are the symptoms that you're having when you're having a heart attack? Right? It was a squeezing chest pressure, elephant sitting on your chest, you're sweating. But what we found is subsequently that women oftentimes had nausea or fatigue or malaise, right? And so that's why women get treated least aggressively for heart disease. So you're right that these manifestations of menopause or other symptoms might be your manifestation of heart disease. And it's important that, again, you have a good trust with your provider where you know that they are, in fact, taking your symptoms seriously. And, you know your body your best. And if you know something isn't right, it's important that you make sure that you are clear about that and advocate for yourself.
Okay. Thank you. And the next question in the chat speaks to tobacco use. And it reads, does tobacco include all forms of tobacco, including marijuana and vaping?
So vaping is worse for you than tobacco. In terms of the marijuana question, there are some areas within medicine where there's been medical research done that has shown particular utility for THC. Right? When you talk about pain management in certain patients, cancer patient populations, and the digestive tract, there's been some data about that as well. What happens is in terms of how you ingest that particular THC is really important, though. Whenever you're using, these carcinogens that come from rolling papers and things along those lines, that's where you're going to be imparting some other chemicals there that are more dangerous.
Okay, thank you. The next question reads, what does it mean when your heart skips a beat? When your heart skips every other beat? I've been told this by my PCP.
Yeah, so I think that's something that, obviously it's hard for me to answer individual specific patients and specific questions like that. I think it's something that warrants additional information. So the electrical system, there's an electrical and a mechanical pumping functioning of the heart. I always say that the light bulb only works if the electrical system talks to it. So, when you're talking about skipping of beats, you want to ask yourself about the electrical conduction system of the heart. At one end of the very end, I'm not talking about this particular patient. I'm talking about generically, of course. I can't speak to any particular patient-specific question. When you have problems with the electrical conduction system of the heart, the question is whether or not, you need to at some point in time think about a pacemaker, or is the electrical conduction system of the heart affected by potentially a narrowing in one of the arteries that gives blood supply to the heart muscle. But if that was something that was noted by the primary care physician, I think the next question would be, do you think that I warrant evaluation by a cardiologist?
Okay, thank you. And then the next question in the chat reads, if a family history is unknown, how would the physician screen for heart disease?
So again, history and physical is very important. It's not uncommon that we don't know all of our family history. And so, auscultation, actually the stethoscope really does matter. Blood work, looking at patients' lipid profiles. So all of those things help in our diagnostic algorithms. And, you still should be able to get a good gestalt of somebody's risk profile. We have risk calculators to help us with that.
Okay. And just to build on that a little bit, you spoke to multi-generations participating in the care of an individual. What resources are readily available to members of that family caring for that individual?
So I think that, again, obviously, I think that that's what we're supposed to do as a healthcare provider, depending on what their specific needs are. I mean, with valvular heart disease in particular, I mean, our patients that come in are 90 years of age. Definitely the kids, grandkids, and great-grandkids are all there. And mostly that support mechanism there shows us that that patient is going to be well tended and cared for. But in terms of as a healthcare community, big networks such as mine are actually very focused on the social determinants of health. To be quite frank, the payers now are in the process of, they have voluntary mechanisms now where you can ask questionnaires asking about what's the support structure like at home? Are you safe at home? Do you have any concerns for your financial well-being? Are you food insecure? And so healthcare systems such as mine are in fact asking those questions and do have social workers and a lot of other staff that can help in the care for those patients.
Okay. And Dr. Horn, we're approaching 2 o'clock. And so to be respectful of your and Katrine's time, I want to leave this conversation by asking you, what can we do right now to take charge of our heart health and get this conversation going?
Sure. So in terms of valvular disease in particular, right? So aortic valve disease is in many instances a disease of aging. So I think that what I would say also is to be somewhat self-reflective. As I noted before, my grandfather was an AME minister, and he also said 40, meaning that many of us historically have thought that if we live 70 years and we're slowing down, that's just because that is what it is. I think that it's important for us to embrace that we're living longer and understand that we might be slowing down, not just because our time is over, but it might be time for us to seek help and care about being able to address some correctable issues as it pertains to valvular heart disease in particular. There's still no question that there are certain risk factors and comorbidities that contribute to cardiovascular disease overall: high blood pressure, diabetes, high cholesterol, tobacco use, family history, and age. Many of those are modifiable. The only ones that aren't modifiable is your age. You're going to keep getting older, hopefully, and your genetics. But you control what you eat, how much you exercise, the manner in which you live your lives, right? But I think that there is some personal accountability there. I think that people on my end of the spectrum need to continue to work on implicit bias, institutional racism, and basically in terms of looking this directly in the eyes. I've been practicing for over 10 years. But I think partnering with us and showing the interest, as everybody on this phone call has, I can see via the chat, is understanding that you're responsible for your own actions. So make sure that you do your end, but also make sure that you push us on our end to make sure that we're holding up our end of the bargain as well.
Fair enough. And we are exactly at 2 o'clock. I want to respect your time. I want to thank you and Katrine for joining us this afternoon. And we hope that it's not a one-off. And you're always welcome to join us at the National Caucus and Center on Black Aging. And to our audience, if we didn't answer your question this afternoon, Katrine has agreed to take your questions and get you an answer, and we'll get them back to you. Thank you. Thank you again, Dr. Horn, and thank you, Katrine, very much.
Thank you.
Have a good afternoon, everyone.
Thanks.